Hay. I am the Executive Vice President of the Medical Society of DC, and the person you will hear speak the least, which is for the best. And then also presenting with us will be, we have some pictures that are going to show up here on the screen. Presenting with me today will be Juan Pablo Segura from Babyscripts. And let's see, Pia, if you can go to the next slide so we can show some Dr. Marco's impressive credentials. There we go, thank you. Juan Pablo Segura, who is the co-founder and president of Babyscripts, and then Dr. Catherine Marco, the assistant professor of obstetrics and gynecology residency program, and then at the George Washington School of Medicine and Health Sciences. Her title and honorifics are too long to go over today, but you'll be in good hands with Juan Pablo and Dr. Marco. And so on the next slide, we'll go through a couple of housekeeping items. You will all be on mute during this presentation. Please mute yourselves at this moment if you have not already done so, or we will do it for you. But in terms of question and answer, we are going to use the chat feature on this platform. So this slide outlines how you can use the chat feature. We'd ask that you send your questions to the presenters. They are ready to answer your questions during and at the end of this presentation. If you send a question to the entire group, I will ask it of the presenters at the end of this session. This is an in-depth presentation, but we will have time for Q&A. I also want to note that this session is being recorded and will be made available after the presentation on MSDC's website. And so with that, we are going to show the agenda right here, and I'm going to turn it over to Juan Pablo and say thank you to him and thank you to Dr. Marco for their time today.
All right, thanks a lot, Robert. Hopefully, can everyone hear me? I hope. Okay, good. All right. So yeah, as Robert introduced, and really appreciate you having us on here. My name is Juan Pablo Segura. I'm one of the founders of Babyscripts. Also very proud to be from DC. Founded the company in DC and we're based in DC, even though location doesn't really matter anymore since we're all working from home. I'm really excited to walk you all through the meat of this presentation, which is just to talk about and highlight some of the real obstacles and challenges that exist in our dear city in receiving prenatal care. And when it comes to actually delivering prenatal care, I'm not the expert, and that's why we brought Dr. Catherine Marco from GW, who is one of our earliest pilot adopters and super users of Babyscripts. So we're really excited to share her perspective on what GW's done with the Babyscripts program. And then we'll also just talk about how technology can really be an incredible conduit to really rethinking how to deliver care in areas where it's hard to receive care. And so we'll talk a little bit about Babyscripts, some of the impact, but I think really what we're on the precipice of is a huge change in how these tools can be paid for and leveraged. And so at the end of this presentation, we'll also talk about some pretty exciting developments on how payers are starting to sponsor some of these innovative care delivery models. So let's get started, and we'll start with just some overall stats, some very sad and depressing stats on just the state of maternity care in the U.S. So whether it's looking at maternal mortality and morbidity, the state of outcomes in this country versus other developed countries around the world, it's really terrible. You look at the amount of money that we spend in the space and the kinds of outcomes that we get. It's very disappointing. Even obviously worse is the racial disparities that exist. If you're Black in the U.S., you're 2 to 3 times more likely to die than your white counterpart, pregnant counterpart. And so when you start looking at some of the core issues that the system has, obviously something has to change. We have to change our approach because what we're doing isn't working. And a lot of what we talk about, you can go to the next slide, Pia, is, obviously whether it's maternal mortality or, other complications, issues like preterm birth, technology can do a lot. I'm not taking the position that it can solve every problem, but I really believe that technology can address at least access to care realities that we have. And it's great that, the smartphone has been almost completely adopted by every patient, every user, particularly in this demographic. So a lot of what we'll be talking about is how do you really use technology in a clinically validated and scalable way to start to really address access to care. And obviously we see that in rural environments, 50% of counties in the US don't have practicing OBGYNs. That's a problem. But if we go to the next slide, you can start to see some of the big issues in urban environments. And right here at home, just because you might not live 50 miles from the nearest OB department or practice, doesn't mean that you won't have issues getting to the doctor in the first place. And there's been a lot of very kind of critical press coverage, obviously, of some of the challenges we have here in other urban environments. But again, access to care is not just something that's happening in rural environments. And I think that's important to highlight. Let's go to the next slide. And so let's kind of dig a layer deeper into DC, since we'll be talking about how GW has leveraged technology to really commit to solving some of these access to care problems. Kind of first and foremost, and I know that there's a new hospital being built in the near future, but when you just look at OB wards in the city, you start to see a very stark divide between west and east in the city. And so again, as you look at, where do you go to deliver, already there's a problem. If you go to the next slide, Pia. And then when we start looking at really the patients that need the help the most, it's not coincidence that you also start to see, massive disparities around just Medicaid beneficiaries and enrollees. So where are the Medicaid enrollees? Most of them are not on the west side, they're on the east side. So not only do we have an access to care issue, do we have racial disparity issue, but when you start looking at where are the installations, where is the infrastructure, it's not where it needs to be. And again, this is reality. And so, kind of to end the highlight, and I know a lot of people are from the district, and so they've seen these numbers, but it's not just infrastructure, it's not just where the people are, but it's also where the complications, the clinical problems exist. Again, it's where the infrastructure is not. So whether it's preterm birth, infant mortality, maternal mortality. So again, really, I know everyone here knows what's happening in the district. So this is a problem. Let's go to the next slide. So, obviously we can build new hospitals. We can kind of train up new providers. I think one of the big challenges, though, in really solving the infrastructure problem is that it's a future conversation. To build a hospital, to train enough physicians, that takes years, if not decades. And so the real question, and really what kind of brought myself and the other founder of Babyscripts to create the company in the first place, is what can we do today? And I think there's a huge opportunity to leverage, obviously, telemedicine, but not just video visits or consultations, but how can we use the smartphone and internet-enabled medical technology to really start to change how we deliver care and to really help the women that need the help the most today, not tomorrow. So let's talk about a little bit of what's happening. And again, when you start to look at not just where a lot of the infrastructure is or where the patients are, but you start looking at what are the specific issues that technology can help address. So whether it's women receiving care and not having to take 4 buses, multiple trips on the metro, changing lines to go from the east side of the city to a clinic on the west side of the city, to monitoring and managing things like blood pressure. If you're not going to your visits in the first place, and you're at higher risk for example, preeclampsia, how can you start to reduce those complication rates? And again, it can't be done through a visit consultation. Maybe it has to be done through technology. And then everything on the postpartum side that has often been ignored or unaddressed in a lot of environments. A majority of maternal death actually comes in the postpartum time period. So all of these areas are huge opportunities for technology. And so we'll be talking a little bit about what Babyscripts does, but I think it's important to start to segment different kinds of virtual healthcare, because it's not just video visits. Video visits can do quite a bit. They can't capture biometric data, for example, but they also are tethered to needing to have a person available. And we're in an environment where we don't have enough OBGYNs across the country. Obviously, there's massive access problems. It takes 30 to 40 days to book a new appointment with a provider. So we have to find ways to start to loosen up these access issues. And so it's video visits, but it can also be things like remote patient monitoring and mobile digital engagement, which is what we do at Babyscripts. So just kind of highlighting the different pieces before I turn it over to Dr. Marco, who has really had the hard job of implementing these tools, but has seen the success of them at the same time. Babyscripts is a digital program very focused on leveraging both smartphone apps and internet-connected medical devices to make prenatal care and postpartum care available at any time and at any place. And so I'll highlight the app for a second. If you go to the next slide, Pia. The first part of our program and any provider that works with us, so we typically sign up provider institutions. We work with GWMFA and MedStar here in Washington, D.C., and we just started working with an FQHC in the city. But any provider that works with us first gets access to our customized mobile experience. So our mobile app, so they can actually customize all of their content and education and essentially make that available through our app experience. The second part of the program, and what we're really known for, is not just using mobile apps to engage and educate patients, but we also ship what we call mommy kits or these devices in these kits that we ship to patients' homes, or we give them these devices as they check out of their clinic appointment. We actually allow the patient to capture their biometric data and their vital information from the comfort of their own home, so that sometimes they don't have to go in and see the doctor. And especially in an environment with COVID running rampant, and issues around waiting rooms, social distancing, trying to avoid unnecessary interactions, that's a huge opportunity as we think about, all right, how do we kind of change or adopt the delivery of healthcare in a crisis and in a pandemic? So the kind of first piece of Babyscripts is really that clinical remote patient monitoring that we offer through our app and by supplying an internet-connected Bluetooth-enabled device. You can go to the next slide, Pia. And again, really going into some of like the deeper parts of the program, a provider like Dr. Marco will enroll a patient at their first visit or at a subsequent visit whenever they see the patient. And then, if they decide to remote monitor a patient's blood pressure or other biometric data point, they will also designate that at that visit. And then we actually will ship the patient a cuff, or we'll give them a cuff depending on the workflow and what the provider would like to do, so that the patient gets the cuff at home and they can obviously take their measurements at home. And if we go to the next slide, we like to highlight, and it's not just prenatal engagement and interaction. And as you look at where the complications come from, especially as we look at kind of the racial disparities and differences in outcomes in maternity care, you start looking at things like preeclampsia, blood pressure complications. They negatively impact certain populations more than others. And so we do a lot around prenatal remote patient monitoring, but we also do a lot in the postpartum time period to solve some of these major issues. So go to the next slide, Pia, please. And so one of our programs is not just prenatal hypertension management, but also postpartum hypertension monitoring. And if you look at where most of the complications come from in pregnancy, particularly throughout the maternity journey, the number one reason for maternal death postpartum is blood pressure complications. So we actually have a program that we've rolled out that's reduced readmissions and taken them from the national average, which is about 3%, to 0. So we've eliminated readmissions and blood pressure complications. And we did this at Cone Health and at other sites as well. So that's just a taste of Babyscripts, just to highlight a couple pieces. And I'd love to turn it over to Dr. Marco, who can talk about how GW and her whole department have leveraged the tool as a research asset, as well as a crucial part of the COVID response.
Thank you so much. If you can go to the next slide, please. Thank you. So we have been working with Babyscripts and utilizing the platform since 2015, but our relationship with Babyscripts really started a few years before that, when they were just getting off the ground, and we really wanted to look at how patients engaged with the platform. And really, when we first did our initial pilot studies, we found that patients really loved the platform. They engaged with it quite a bit. New moms who are on their second pregnancies, really everyone did appreciate the app, and we found that overall patients had higher patient satisfaction while using the app. As we started to think about what we could, and that was the app with the blood pressure monitoring, as we thought of looking forward, how could we reimagine prenatal care? What are the kind of redundancies in prenatal care, and how can we really use this technology to move more towards precision prenatal care? We thought of the reduced patient visit schedule and what we call as the optimized patient optimization. We call it the optimized prenatal schedule at GW. And with this optimized schedule, what we found was that after doing our initial pilot studies and then subsequently prospective randomized trial or controlled trial, what we found was that patients not only still really love the app and love the blood pressure cuff monitoring, had increased patient satisfaction, but they did end up having a reduced patient visit schedule that really worked with them and for them. Obviously, we're in DC. Not only do we have a huge subgroup of patients who have trouble with access, but we also have another subgroup of patients who have childcare issues, who have jobs that really don't want to take time off or can't take time off in order to come see us. And so with that reduced patient schedules, patients were extremely satisfied, but in addition, they were able to not have any difference in their patient outcomes. And so those were the big things that we found with our with the Babyscripts app in our first studies. As we have been utilizing the app and utilizing the platform more, we have, and this is just an outline of kind of our practice, we have a lot of patients that are concentrated on the east side of the city. We really wanted to ensure that this was an app that was not utilized just for one small subset of low-risk patients. We wanted to make sure that this was an app that was in a platform that was going to be utilized by all of our patients. And we really wanted to make sure that this was a platform that was going to be able to be successfully used in our patients who were the most vulnerable. And really, this does put a ton of information and also the ability to screen for high-risk conditions remotely in patients who otherwise would maybe have difficulty accessing care and potentially a problem or at increased risk, as we saw in the initial slides that Juan Pablo demonstrated, really have much higher risk of having these high-risk conditions. And this allows us in more real time to intervene and to identify patients that would make us concerned that we would want to monitor more closely. Move on, Pia. And so this is what we thought of with our original, a lot of those prenatal visits that we used to do, all 12 to 14 of them, a lot of them were to check in with the patient, to make sure she didn't have any questions, to provide resources that we knew were evidence-based resources, and to ensure that she was getting the screening that she needed. Unfortunately, a lot of those patients were not showing to those visits. And so what we now, with our reduced patient visit schedule, we're able to not only still monitor the patient, provide all of the routine screening that she needs throughout the pregnancy, and you can see those visits are sort of targeted with the main kind of events and the anatomy ultrasound, her NIPT, her glucose screening. But also those prenatal care visits are we're able to engage with the patient a little bit more on a higher level because we've already given her a lot of the resources that she needs. She's had access to them through the app. And we also are able to take a look at all of her blood pressures and her weight and able to monitor those. And hopefully if there was an intervention that needed to be done, it didn't need to all happen right there at that visit. It could have happened more remotely prior to that visit. And we can concentrate on more high level conversations with our patients. In addition, with our COVID response, we have been enrolling patients right at the very beginning. At first, we were utilizing Babyscripts only for low-risk patients. That's what we did the initial studies in. However, since COVID, we've actually enrolled every patient. The part of the reason for that is that we know that patients are not coming into the office as frequently. We want to make sure that we don't have as many providers seeing patients to ensure in the clinic to ensure social distancing and make sure that becomes, and that's difficult, as you all know, with cramped clinic spaces. And so we're able to do that now much more readily, that we have all of our patients enrolled in the app so that we know that they're getting good information that's all evidence-based, in addition that we've vetted and looked at. And we also know that we're able to monitor them to ensure that we're not missing anything like a development of preeclampsia with these expanded prenatal care visits. Next slide. With the resources that we've been able to provide, one of the huge benefits of the Babyscripts platform is that it really is, like Juan Pablo said before, customizable. We're able to push out our COVID-19 visitor schedule, which is constantly changing. We're able to push out information about the prenatal care schedule and how it is the spaced visits don't change the patient's outcomes, as far as we know with the studies we've performed previously. We're able to discuss with the patients kind of things that they need to think about when the baby comes now with COVID. We have pushed out a lot of information about mental health and stress, and this was the impetus to put in additional domestic violence, as we've seen a surge of domestic violence, unfortunately, with the pandemic. This has allowed us to push out information on that as well. Here's a detailed report of our enrollment of our patients. You can see a huge spike in March and April as we started to universally enroll patients in the platform. So this was kind of that big spike in the enrollment, which then sort of tapered off as we were only enrolling new patients. And as I look forward at this, I anticipate that even post-pandemic, hopefully whenever that is, we'll continue to enroll universally all of our patients into the platform, because I do think that not only have the patients clearly seen a benefit from it, but also as providers, we've also had a very good experience utilizing the platform with our patients, and the ease of use, but also the ability to really keep a much closer eye on our patients. And so this is one of our patients saying how they feel empowered, being able to keep track and being able to monitor themselves more closely instead of needing to wait for each appointment. And with the back and forth communication that does occur, especially as there are what we call triggers, if there is an abnormal value, we're able to allow the patient to really engage in her prenatal care, and to the extent that she hasn't been able to engage in prior to this. Next. One of the, I was very sold on the platform as far as the potential and the possibilities of the platform right from the beginning. However, this is one case study of a patient of ours who, this case, as well as there were several other ones that kind of all happened at the same time, really solidified my belief in the platform. And this was a patient who was enrolled very early in the Babyscripts platform, and very early in her pregnancy, right at that very first prenatal care visit. She ended up taking a lot of blood pressure measurements. We usually ask that patients take blood pressure measurements at least every week, and she was taking at least weekly, sometimes even more. Every single one of her blood pressures was normal throughout her entire pregnancy. She had a cesarean delivery, which was uncomplicated. She was discharged at normal time. And then subsequently on postpartum day 4, she noticed some increased swelling and an elevation in her blood pressure. This triggered a note to the on-call provider, and she ultimately was asked to come to the hospital after several more blood pressures and communication with the on-call provider remotely. She was asked to come to triage in order to have an evaluation. You can go to the next slide. At that time, she was diagnosed with preeclampsia with severe features. She received postpartum magnesium. She was discharged home with blood pressure medication, and subsequently we were able to monitor her remotely, keep her at home. She didn't need to come back with her baby in order to have her blood pressure checked periodically. We didn't have to worry about dropping her too low as her blood pressures naturally came down postpartum. We were able to titrate her medication first up, actually, and then we were able to titrate it down remotely, and able to really key in to what she needed during that postpartum course. By the time she was 11 weeks postpartum, she was normotensive. She came off of her blood pressure medication, and we were able to do that all remotely except for her 1 6-week postpartum visit. And so we were very connected with her, and she really helped her to control her anxiety, as you can see in her quote. She knew that we had her back. We knew that she felt very well cared for, and we were able to give her the care that she needed at the time she needed it. And so as I sort of look forward into where we aim to go with our research and our platform, is really not only identifying high-risk conditions, but really targeting where in pregnancy people need interventions as an individual patients and moving towards precision care. Also, utilizing the platform much more extensively to reduce disparities in the district, and how can we ensure that all of our patients have universal access to the platform, universal access to monitoring and for high-risk conditions, and how can we anticipate which patients are going to need resources much earlier. And that's where a lot of the partnership with payers comes in. And Juan Pablo is going to talk a little bit more about how that works.
Yeah, no, and thanks a lot, Katie. Number one, incredibly proud of the work that we've done with you and the GW team. And, you know, it's the GWMFA team, Dr. Gaba, the MedStar team and midwives at MedStar, Laurel Patchen. I mean, some of the most progressive champions and early adopters out there. So, you know, it's been really an honor to work with you and to intervene in these patients and to help these patients. And I think when you look at just the vision that you have, you guys have committed to solving disparities in care by making technology available to anyone, regardless of payer, regardless of commercial, Medicaid, uninsured. And so, you know, one of the things that, you know, obviously we've seen is that while GW is a big organization, not every organization has the budget to be able to invest in these initiatives. And so one of the things I'd like to highlight and that I'll kind of end the presentation, or at least our portion of the presentation on, is really the work that we've done with the managed care organizations in Washington, D.C. Because if you think about it, at the end of the day, these tools really not only help you deliver care, but they also help control cost and dramatically improve outcomes. And the payers benefit from that. I mean, there's no way to go around that. And so one of the things that we've done, and you can go, if you can go to the next slide, Pia, I'd appreciate it. One of the things that we've done is, and we initially did this kind of on the behalf of our customers, but it's become kind of a massive movement that we're seeing across the country, is we've now brought in large managed care companies that most of our provider customers work with to actually have the payers start to pay for the cost of Babyscripts. And so in DC, we have AmeriGroup and AmeriHealth, the two kind of larger managed care companies. And I would say, you know, the more kind of innovative, if you kind of talk to the leadership and their vision for what they have in DC, you know, they've done a great job of kind of stepping up to the plate and helping sponsor the cost of these programs for their members and obviously the patients that you see and that need these different tools and interventions. And so we've created a program that any provider can now jump onto. We call them joint deployments, which is when a payer, a provider, and the patient, I'm running out of hands, but when they all are on the same experience, tech experience. And we think that that is the future of how digital healthcare gets integrated into the delivery of care. We think that care coordination is probably one of the best things that can happen. And it really does take a village. And there are so many people that have resources that are just not talking to each other. You know, the insurance companies have social workers, they have people on the ground, but they're not talking to the provider community. They're not, you know, really getting that at the point of care data and insight that they need to really address the risks that patients have. And so we created this program. Now AmeriHealth, AmeriGroup, MedStar at the Midwives and MedStar group, and the clinic in Washington Hospital Center in GW are on joint deployments. And so with the joint deployment, AmeriHealth doesn't just pay for the higher risk remote patient monitoring that we do to make sure that these patients with high risk conditions get better care, but they also pay for other kinds of experiences. And so if you can go to the next slide, Pia, please. I basically did these two slides in one slide, so we can go to the next one too. But you know, one of the things that we've also invested in, and it's not just shipping a device to a patient and letting them take their vitals at home, but it's also changing the software and the software experience to address specific risks and also help connect moms to specific resources. Because the risks that patients have aren't always clinical. A lot of them are social. I mean, talk about social determinants of health and how you can connect patients to specific resources when they need it, whether it's you know, access to transportation to get to the clinic, or you know, domestic violence, or just food insecurity. And so we created a program with a few of our health system customers 2 years ago, where we changed the app experience to a healthy pregnancy checklist and also a bidirectional chat to actually screen for social determinants, connect patients to community resources that an AmeriHealth or an AmeriGroup pay for in real time, and then essentially allow them to have that connection point in a much better and faster manner. And so through these kinds of risk identifications, again, they're not just clinical. Some of them are behavioral. Some of them are mental health oriented. Like we have a whole program around mental health screening and postpartum depression screening. But you can see the benefits through this increased engagement. We've seen better attendance to prenatal care appointments. We've, on average, when we put patients on what we call our Care Navigator experience, which is changing the app to screen for social determinants and connect patients to resources, we've seen that we're identifying 2 social risks per patient. So a lot of these issues, and that what we've committed to is not just looking at clinical physiological, but also going beyond that kind of purely numbers-based dynamic and thinking a lot more about environmental risks. So you can go to the next slide. And so we have multiple kind of examples of what we've done in other markets. For example, with WellSpan Health, we actually created a substance use disorder experience, very focused on opioid addiction and connecting moms, screening moms and connecting them to community resources to help them with their addiction and with their substance use. And so you can see some of the interventions here, identifying risks, connecting patients to specific support programs. So they can be, again, on the addiction front. They can also be on the mental health side. Let's go to the next slide, Pia, please. Another use case around depression screening. And so we've had multiple interventions. And again, our vision for what technology can do is address different kinds of risks. And the beautiful thing, and when you connect the physician, is the relationship that a patient has with the app, with the service, with the monitoring. When a clinician's involved, really changes the nature of their compliance, their utilization. Katie talked about satisfaction. So we have a big vision, and we have great partners here in the district that are committed to leveraging these tools in different ways. And I think that's the last piece on the social side. Oh yeah, and again, these are kind of very kind of quality metric, infrastructure and institutional related metrics. But you can see whether it's reductions in no-shows when you empower patients. And I think at the end of the day, when you give them a program or a tool like this, you also make them take more ownership in their care. And so we've seen less no-show rates or reductions in no-show rates on the prenatal side and also on the postpartum side. And so I think that's part of the general kind of thesis and the work that we started doing, that we continue to do here in DC and around the country. And we actually are in 28 different states right now, in almost 60 health systems, about 58. So, we're really proud of everything that we've done with GW and others as well. The last thing I'll update, and this is kind of more of a market insights and just to kind of show or give a little bit of a perspective into what is happening across the country in terms of policy changes and potential kind of updates to reimbursement matrices and other assets. And so I don't know if everyone's been following the Postpartum Expansion Act. In our space, it's pretty exciting, but this was passed in the DC Council. And so they first kind of expanded the coverage that's possible in the postpartum time period. So it's not just, one visit or 6 weeks. It's a much larger kind of initiative to really look at giving moms more support after they deliver. But one of that is in and of itself incredibly exciting and I'd say crucial. But one of the other very innovative approaches, and I haven't seen this in any other environment, is the DC government, at least on the DC Council side, has created basically a digital health mandate. They're mandating that plans of all kind of shapes and sizes and kind of payer mix actually reimburse for these kinds of interventions at the point of care. And so everyone's been waiting for the day that telemedicine would have parity with kind of in-person visits. You look at also just general kind of pronouncements from ACOG. ACOG has specified that, giving women options in their care is incredibly important, especially in the postpartum time period, and that these tools can do just as good a job in helping moms throughout their postpartum experience and time period. So again, you're seeing that this change isn't just happening on the innovative physician kind of practice side like a GW, but you're also seeing legislators really kind of identify this as a huge tool that can impact outcomes and solve a lot of disparities in their respective geographies. That's pretty much our update and some of the narrative behind what GW is doing in Babyscripts. And would love to answer any questions and go through. I don't know how we want to manage, questions that have been shared or sent to us, but very happy to kind of open the floor up.
Well, I'll take the microphone for a minute to allow both of our wonderful presenters to get a breath of, just take a breath and to get a drink of water if need be, and just say thank you both very much right now for that wonderful presentation. One of the problems of my role, which is kind of moderating and handling this type of presentation, is I have a notebook that I write down questions throughout that I'm planning on asking, but most of them are already answered. So that's how thorough and wonderful of a presentation we saw today from my end. I would like to remind everyone to ask your questions in the chat box. You can direct them directly to the presenters, or you can send them to the general chat and I will ask the questions of them. But I will ask the first question if that's all right, unless there's one burning question in your inbox. I would be remiss to not ask about data privacy with the fact that we're holding this webinar on the same day that 4 major tech companies are being grilled on virtual Capitol Hill. Can you all talk about how working with patients around questions, and let me think of the best way to phrase this. Data privacy is always an issue with new technology. Can you talk a little bit about how you all navigate both from the technology company side and the provider side, working with patients to make them feel comfortable using technology to help with their pregnancy?
Yeah, so I'll maybe take the first stab at that. And Katie, I would love to hear how patients react when you do kind of introduce them to Babyscripts, because I think there are sometimes a lot of misconceptions as to what patients are looking for or the kinds of experiences that they want to have. So I would love to maybe hear a little bit about that. But just in terms of the program, our program, and how we look at data privacy and security, number one, we are a clinical tool. So we actually sign some pretty robust, for example, business associate agreements with our health system partners. We don't sell data. We're actually not allowed to sell data to anyone because we sign a BAA in the first place. We also don't make money off of marketing or ads. The app that I showed you, it's fully owned and administered by GW. So we aren't kind of unilaterally adding any kind of extra links or sites or other references. So whether it's kind of operationally with the agreements that we make, the IT security risk review processes, as we all know, right, Dr. Marco, are pretty robust from the health system side. But no, in terms of just, our approach, most pregnancy companies actually will hide very specific provisions in their end user license agreements. Essentially what the users acknowledge when you're like trying to get into an app and you just click agree, 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 agree. Most of them actually have clauses in there where they sell data. So we don't believe in that. We also contractually aren't allowed to do that. And we kind of follow all the HIPAA kind of ordinances because obviously we're a clinical tool. So that's just our approach, but I would love to kind of hear, Dr. Marco's perspective.
Yeah, I think when I first pitched the app to my patients, the vast majority of them think it's just a really cool idea. And they really do want to, a lot of them have already accessed a ton of websites. A lot of them have already gone down the rabbit hole of Google. And so to be able to have something like this, where they know that I have literally read every line of script and written a lot of it in that app, that they know that it's coming from a place that is evidence-based, that has a really, the look of it is clean. And so it really does have a vast, appeal to a lot of patients. I have really only had a handful of patients address concerns about the privacy issues, and that those patients I have, and it's because again we work in one that's like works for security and everything on a government level. So being in DC, we have patients who do all kinds of work, and so I just direct them to the customer service at Babyscripts, and really all of them have had their questions answered to their satisfaction. And so it really is a great relationship with the company as well to kind of address some of those concerns if needed. otherwise, they know that this isn't like some of those other apps that you can find where there's, again, ads popping up every 5 seconds and having to kind of sweep that away to get to the content. And I think that they really do appreciate that, and it makes it something that I feel that I can recommend with confidence to the patients. And the vast majority of them, like I said, are really engaged and excited about the concept, not only from the reduced visit schedule, but also just the fact that they have that app.
Great, thank you.
Mm-hmm.
Sorry, I was on mute there. I would only say that, I mean, and also in a very digital first world, I mean, most patients, you know, the kind of the old school kind of way of patient education was that OB packet, the pamphlet, and you know, most patients are either leaving those packets in the waiting room or in the backseat of the car and never looking at it again. So I mean, even just on the virtualization and digitization of your content, I think that's always been something that most of our patients, like, and the user feedback, always share with us.
A lot more trees.
Yeah. The environmental first, always. I will say I don't want to share a specific name, but so I did get a question. So maybe I can read it out loud. Is that okay, Robert? Yeah, okay. Question, essentially, I'm going to try to paraphrase it so that it's applicable to both me and Katie. But essentially, how is the information sent back to the provider team? So I wonder if that's not just kind of content, but also maybe triggers and alerts, because that's obviously really important part of our program. And then I don't know if I understand the rest of this question, which kind of relates to how payers, you know, get access to data, or how we link kind of patients, et cetera. So maybe I'll just take a quick, like, 5 seconds on just how we think about our work that we do with the provider community. So we kind of have 2 ways of sharing information back to a clinical team. Number one is we prefer to integrate directly into the medical record. And that's actually our kind of standard way of operating now. So we'll do what's called HL7 integration. So patients can be automatically enrolled onto Babyscripts. The data points that are captured at home can actually be fed into the flow sheets automatically. That's not what we do at GW, because GW is a kind of a legacy account. So we kind of created workflow around them that just worked really well. And so we haven't had to integrate. But maybe Katie, you want to talk about how we work with your workflow and how we kind of, you know, manage the data or kind of any follow-ups.
Yeah, so we have the Babyscripts in general has a provider platform called Diana, in which you can log on as a provider and take a look at every single one of your patients that are on the platform. And you can search by name, you can search by who enrolled them. So if you have your own personal patient panel, you can look through that. And that's just a really way to see all of the data points, but it also you have a graphic view of it too, which is really helpful, especially for gestational weight gain and some of these other factors. So that is the provider platform. And typically what we'll do, since we're not integrated in our health system, is just that most of us will have a dual screen up. I have my laptop in my office. And so I have Diana up on my laptop and I have my patient chart there. And I'm able to just very quickly glance at the patient's blood pressures. In addition, if somebody does have a trigger, we have internal systems through the app where it does ask a patient to recheck her blood pressure in 20 to 30 minutes to ensure that it is still elevated. If it's not still elevated, it doesn't necessarily send a message to the provider, which is appropriate. It also has symptom trackers and checkers, so you can log your symptoms. And if somebody does have an elevated pressure plus symptoms, that would trigger to our triage system. And so how our triage system works is that it would actually go to the triage nurses during the day or the on-call provider if there's critical levels. In addition, if there's not really critical levels or the blood pressures normalize, it actually sends what we call tasks to our inbox. And so it actually will then go into the provider inbox or the triage inbox so it can be addressed the next day. So we're able to set those parameters, and actually was just on an email chain today where we were tweaking some of the parameters since we have so many more patients on the platform than we had previously. We're getting a lot more triggers. And so we're able to adjust our trigger parameter and our workflow very easily in order to make sure sure that the appropriate follow-up is happening for each individual patient. And then really the patient doesn't necessarily need to come in and say, hey, here's my log of my little scrap of paper that has all of my blood pressures written on it, or my sugars, or whatever you're tracking. You're able to then say, I've actually already have all of your blood pressures here. I've been able to look at them. I've been able to identify any areas that what was going on this day? Are you, it seemed to be a little high and then it got better. She was like, well, my grandma tried the cough on, whatever it is, so I think that it is something that we're able to track in real time. And I'm actually don't have to rely on the patient, or the patient doesn't need to remember when she comes in, gosh, I forgot my log at home, but I'm pretty sure everything was normal. So this is a really nice tool for me to be able to monitor the patients so much more closely.
Yeah, and I'll just kind of tack on to that and say every provider is a little different in how we map these alerts to however you do triage, or however a provider does, after hours, on call. And so, yeah, we make sure that all of that is kind of custom mapped out so that the solution runs turnkey, which is really important.
And then I think Juan Pablo, the other part of the question was about what information maybe is going directly to the payers and how they're using it. Does that seem?
That piece, I mean, in a joint deployment, when a patient is enrolled by Dr. Marco at GW, for example, we actually tag what payer they have. And then through that first time user experience, the patient actually acknowledges not only that they're okay with, the terms and conditions of Babyscripts and the remote monitoring, but they also acknowledge that they would like to share their data back to their payer as well on the care management side. And so through the app, like I mentioned, it's not just physiological remote patient monitoring. We identify, specific social risks, behavioral risks. And so that information, as it's either being captured like biometric through our remote monitoring, or through, we have these quality checklists or chat. Actually specific issues are flagged to the payer care management team for them to follow up as well. So there's kind of a combination of both authorizations and then also follow-ups that occur. And we kind of agree what the providers want to take care of. And then we also kind of confirm what they don't want to follow up on and what they want the care management team to follow up on. So that's typically how we do a joint deployment.
Yeah, and I think that the great part about that is that this used to be on paper, and it used to be mailed in or faxed in to the office, and then somebody would go through all the papers and then put it into their system and look at it. And so it really is something that has essentially created the ability to, in real time, access these resources, like things for food insecurity or mental health resources, substance abuse resources, things that we don't necessarily have, since we don't always have an in-house social worker or anything else at all of our sites. And so this has been really a big benefit to identify all these high-risk conditions early. And then I have a question here that is looking at trends in the app by under-resourced patients, and kind of thinking about patients who may have financial insecurity or do not have access to smartphones. And then is the app also able to capture other chronic disease metrics such as blood sugars for gestational diabetes? So the first part, we currently are using the app for patients who do have access to a smartphone. We do have a Spanish enabled app as well. So that has been a huge benefit to be able to not only have just English speakers use the app. So that has been great, but you're right, it's hard if the patient doesn't have access to a smartphone. It is something that the app probably isn't going to be the best tool for them. And so it is really are being able to identify which patients this is going to have the most benefit for. However, if they do have the smartphone app or anything else at the very beginning, then we can hopefully identify those with housing insecurity, financial insecurity, job insecurity, and get them to the resources that they need early. If they don't have that at the very beginning, though, it's more challenging. I don't know if you've had this come up in your other groups, Juan Pablo.
Yeah. And I would say, one of the unfortunate kind of exclusion criteria of Babyscripts is not having a smartphone app or just a smartphone. I mean, at this point, that population is in the low single digits, right? I mean, just because in this demographic, I mean, just the numbers in this demographic, 94% of patients between the ages of 18 and I believe it was 39 have smartphones. So again, you're looking at the fringe use cases. We do have web apps, so you can access Babyscripts from the app kind of content itself from a browser, but you can't do the remote patient monitoring without accessing the service through an app and through a smartphone. So that is a limitation. It's obviously a very small segment of patients. And then, just on the blood sugar side, we actually do have a gestational diabetes product that monitors blood sugars. We haven't deployed it at GW, just because, every health system focuses on what they prefer and what was available at the time. And GW, built the Babyscripts blood pressure monitoring system with us. So, that's what you guys have historically used. But yeah, we do offer that as a separate service and it's the same mechanics as we would do blood pressure monitoring with blood sugar management and monitoring.
Yeah, and we do have our patients, we ask that they also do weight and just manually input their weight, which has been really helpful in monitoring gestational weight gain. And you're right, we haven't used the blood sugar monitoring yet, but we are just starting to deploy the postpartum hypertension module. And so really there's all of these, the possibilities are endless. We're hoping to build a more robust mental health and postpartum depression screening. I just was chatting with Anish today about how can we look at, for AIM bundles, looking at venous thromboembolism and VTE, and how can we monitor patients make sure that they're taking their Lovenox, and how can we build that into the app and with the ability for the triggers. And so I think that there are so many possibilities with a platform like this, and really you just have to find a good partner and dream it up and try to think of what else can we do to make sure that our patients are getting the best care possible. And that's where I think that having companies like Babyscripts and having partnerships like this are so vital. And it's really important for us as physicians and midwives and nurse practitioners and people caring for women during the prenatal time period to form these relationships so we can, one, really know what's out there and what the possibilities are, and then we can actually make products that are really useful from not only the clinician standpoint, but really can change outcomes for patients. And so I think that that's really the possibilities for a platform like this are really endless.
Yeah, and I think sometimes what we get when we have intro conversations with different provider teams or groups is sometimes the whole realm of digital virtual is sometimes overwhelming, right? It's like, where do you start? What do you do? What patient group do you focus on? And so one of the things that we always encourage is you kind of have to crawl before you walk and, walk before you run kind of thing. So a lot of our providers will start with just digitizing their education. And that's just a simple thing, not controversial. Sometimes you have different physicians or different providers in a group that aren't as comfortable as others in doing virtual care, but nobody says an app's a bad idea for education. And then you kind of build on top of it. You build on top of, whenever kind of organizationally or institutionally you're ready to kind of make a workflow change to optimize low-risk patients or to go to high-risk patients or do postpartum hypertension, workflow changes. So, because GW started with the app, then did low risk, and it's kind of slowly added on and bolted on additional services. So I think that's really important. I know we're getting close to time. I don't know if I have any other, I don't think I got any other.
I don't think I have any other questions in my inbox.
Yeah, well, we have enough time for one more question. I don't see any on mine either, so I'll ask my favorite question. Let's play the prediction game, and I promise I won't hold anything against you. 10 years from now, what are we looking at in terms of taking care of and treating pregnant women? What does this webinar look like in 10 years from now?
Do you want to go first, Katie?
Yeah, I'll take it. Yeah. So I think that 10 years from now, I think that this is going to be the norm. I think that this is going to be how we are universally accessing and administering prenatal care. It's going to allow us to really identify early patients that are at risk and intervene at the right times. And that's going to really create an environment of really personalized care. I envision a time when you start to see the gestational weight gain pick up. The app or whatever we're accessing automatically pushes out additional resources and, a calorie tracker or an activity tracker. Looking at, and at that point too, we'll have a significant amount more data. Just did a systematic review in the Green Journal of telehealth interventions. And there's not a lot of good randomized trials out there looking at these telehealth interventions that a lot of us are adopting. And so by then we'll have a significant amount of data, I hope, to see that not only is smoking cessation interventions work, but these interventions for gestational weight gain, these interventions for preeclampsia, these interventions for diabetes in pregnancy, and ultimately improve outcomes for all women. We also will see that the penetrance into communities that are rural, that are not rural, but in DC where they have limited access is going to be so much higher. And I hope that we eventually get to a model where the minute a woman gets pregnant, she's able to get care, she's able to access it in her home where she is comfortable in her community and still have the ability to really connect with her providers in a way that's meaningful for her and a way that's meaningful for us too. Part of the reason that we do this is because we love what we do. We love caring for women during their pregnancies and in general. And sometimes you fear that loss of the face-to-face connection is going to be a problem, but really we're utilizing this technology to really enhance the moments that we have face-to-face and connect more frequently in different ways.
No, that's great. And yeah, it's hard to kind of add on top of that, but I will, and this is kind of part of just our vision at Babyscripts is we think that the 14 visit schedule as we know it will kind of completely be innovated out of being the standard of care. We think that the second that you know you're pregnant or go in for your first visit, your care is going to be completely personalized based on your risk and based on your preference. So Katie talked about how, it's how important it is to deliver care at home or in an environment where a woman is comfortable. And right now, what we're doing in the process for receiving care is a very uncomfortable process. Think of going to the doctor's office in the middle of the workday, taking 4 hours off of your workday to battle DC traffic. I know there's no traffic with COVID, which is, I guess, a benefit of this ridiculous pandemic. But the typical circumstance is you're battling traffic. You're spending 45 minutes, you're paying for parking, you're waiting in a waiting room that is never the right temperature for 30 minutes to an hour, and then you're getting seen for 5 minutes. When you think of the kind of patient experience that creates, that's not the kind of patient experience that people want. And so whether it's detecting risk better and more appropriately, it's retooling provider time so that Dr. Marco can focus on the patients that are higher risk and that need more care and need more attention. I think you're going to see a whole system of obstetrics that's completely turned upside down from standardization to personalization. And the only way to really do that, and I'm not trying to do this directly, I know it might sound like I'm pitching Babyscripts, but you really do need a end-to-end virtual tech experience. You can't do that by just having like templates in an office. Like you need to have some level of constant connectivity between the patient and the provider. And so that's where I think, you're going to see, you're already seeing that. I mean, GW is doing some of it for the low risk patients and others, but on a much larger scale, I think you're going to essentially pick the kind of care like a drop-down menu and automatically everything else changes from there. So that's my prediction.
Both of those answers were incredibly powerful. So I think that is the perfect place to end it. I want to thank Juan Pablo. I want to thank Dr. Marco for their brilliant insight and presentations and discussions about a very complex topic and the way that the GW and Babyscripts have been working on this topic. So thank you all also for attending. Please keep an eye out for a survey post-event. We really take your feedback to heart and use it to plan these events. And so I'll say one last thank you, and everybody have a safe and wonderful evening.
Thank
Thank
you.
you.
Enjoy.